All right. Let's go ahead and get started. See, look, it's already jumped my slides ahead. The heck? There we go. All right. We're going to go ahead and get started with our last session of our training for this year. So thank you to all of you who have stuck through with us. We have some guests with us for this session. I'm going to kick it off, and then as each of them come to present their portion, I'll let them introduce themselves at that point. So, see, I told you, it's crazy. Back. I think this is where we're supposed to be. So the things that we're covering, we're going to take a quick look. I'm going to talk just a little bit about where we are with mental and behavioral health services in SBAP today, as far as what we can or cannot bill and those kinds of things. And then I'm going to turn it over to my colleagues from OMHSAS who are going to talk to you about some of the other services that Medicaid provides that support students that you can't bill through school-based, but they're out there as part of the larger safety net to cover your students and their needs. And once they talk about that, then we're going to come back to what the future might look like in school-based going forward. So right now, we have sort of one lump of services, right, that you guys can bill for that address a small portion of the mental and behavioral health needs that your kids have. So these all come under psychological counseling and social work services, and these are the providers that are currently authorized under Pennsylvania's Medicaid state plan for school-based. So at this point, no, I did not. Okay. Sorry, it's been a long day. All right, so we have over 500 LEAs that participate in the program at this point, including school age and early intervention. There were 506 LEAs that completed cost settlement for 22-23. Only 197 of those claimed services in that category of psychological counseling and social work services. And that actually is consistent with what we saw in responses from a survey that went out earlier this year. And so we're going to take a little look at some of the responses that we had from that survey. And again, this is something that we developed jointly with our partners in OMHSAS. And we sent this out. We got 189 responses representing 172 unique LEAs. So if you feel like this doesn't represent what you know, it might be because your LEA didn't respond to that survey. But we'll have more options to get your information. So the current gaps that are most frequently identified is the ability to hire and maintain the staff that are needed to provide these services, and limitations around the providers that you can bill for, right? So we just have that abbreviated list right now that you can bill through school-based for. And the fact that because our school-based program is currently limited only to those students with an IEP, you aren't able to bill for services that are delivered to students with 504 plans or who are just in the general student population. So when we look at who answered our questions, mostly it was folks who were director of pupil services or special education, but we did have a few others who provided some feedback through this. Most of the folks who responded have been involved with the program for 5 or more years. So that was nice because we know that it's not just a right now feedback response, but actually folks who've been looking at this for a number of years. And about half of those who answered identified their district as rural. See? There we go. All right. So when we look at kind of the general response, only 5 to 10% said any part of what they were doing with behavioral supports or what they had available to them as behavioral supports was outstanding. Most of our respondents felt that funding and sustainability for these services is insufficient and in many cases a cause for concern, basically meaning that they don't have what they need to support their students. But over 70%, because I guess, there's certainly the limitations that currently exist with school-based, but also, when you just look at the breadth of the need for these kind of services, over 70% of the folks who responded to this survey indicated that they are using outside health supports to meet these needs. And so, again, what we want to do today is spend a little bit of time sharing with you what these outside services look like in case you're not familiar with them, and then come back to where do we go from here for school-based. So now I'm going to turn it over.
Thanks, Jen. It is our pleasure to be here today. My name is Courtney Malecki, and I work in the Office of Mental Health and Substance Abuse Services in their Children's Bureau. So we have a whole Children's Bureau that's dedicated to all day, every day, talking about children's behavioral health. That's what we love to do. That's what we get excited about. So we'll have all our contact information. And really, I just wanted to say it's been a pleasure working with Jen and her staff over the last couple of months and just getting to know more about the school-based access program, talking about what things there might be in the future coming up, and really looking through the survey, seeing where the needs are. So based on that information, what we're going to present today are the things that we think would be most pertinent to you, but certainly we have a wealth of information about other things. So if there's something that you're interested in that's not covered in our presentation today, or you want to have a side conversation about something, we're certainly open to doing that. I'll be monitoring the chat and trying to answer all the questions that come in that way. And we're just going to give it our best shot for giving you the information you need. First, all right.
Hi, my name's Amy Kabiru. I'm a clinical consultant within the Children's Bureau at OMHSAS. And I've been pretty heavily involved in some of the services that we're going to describe. Would you mind? Thank you. So up here, we have listed a variety of services that are available to children, youth, and young adults throughout the Commonwealth that can be accessed through the Medicaid system. So we have those services listed. You're going to see something like case management. So those are more of your less restrictive type of services to more intensive services. So the last service that you'll see there is a psychiatric residential treatment facility. So that's a more intensive service where the child is no longer in their home. So we have, like I said, a wide array. I would say that the most common services that you're likely going to encounter within the school setting may be outpatient services. We do have the ability to license outpatient clinics, which are actually housed within a physical school site location. So it would be a provider agency that's actually housed within the school. So they operate separately from the school itself, but those services are available within that location. And then the next service that we have listed here that I think folks probably would be more familiar with are intensive behavioral health services, or IBHS. And these services include individual services, applied behavior analysis services, and group services. So these are community-based services. They're going to be delivered wherever the child needs them. So that might be if they're at a daycare setting, they might need support there. They might need support throughout their school day for behavioral needs. They may receive some services in the school. They may need some supports at the home. So it can really take place in a variety of environments. It's going to be where it's determined that it's medically necessary for that child, youth, or young adult to receive that level of support and treatment. I think probably also family-based, that might be another one where you may see some folks that would be coming in and out of the school that may be providing some therapy. Those youth are at risk for out-of-home placement. So their psychiatric needs may be so intensive that we're kind of at a standstill. We're trying to get those supports in place so that they can remain with their family and have those supports from their home environment. Would you mind turning to the next slide? So behavioral health services and how do we access them? The mental health system is a little bit different than the educational system and how some of our services are accessed. So a child would need to be evaluated and have a written order to determine if it's medically necessary for them to receive services. So that would be meeting with potentially like a licensed psychologist, certified registered nurse practitioner, somebody who's able to prescribe those types of services. I did just want to clarify though, that the evaluation that is completed for our types of mental health services is different from a school evaluation. So if you have a school evaluation report and it says that a youth has an autism spectrum disorder and they need supports for those services, you can't take that eval to a mental health provider and say, okay, we have our autism diagnosis, they're recommending supports. So unfortunately, the two systems do not work interchangeably. So it is important to try to get linked up with the community if there is, that need for additional supports. And if you contact SBAP, which Perry's going to talk about a little bit more, or some other agencies in your community, they should be able to assist you with the process of linking up with somebody to get access to an evaluation. Yes. It's going to vary depending on the level of care. Oh, sorry. Yes, she was asking if the services for the evals for services are only valid for 90 days. So there's going to be different criteria for each type of service that's provided. And I should also highlight for outpatient, for example, there's not as intensive of requirements for accessing that type of service, but the majority of mental health services, you do need a written order or a formal evaluation to access those. So once you have services, you may see, some folks from the community that want to come in and provide some supports in your school. And I understand that sometimes it can be confusing or, why are some of these folks coming in? Do they just sit in the back of the classroom? What's taking place here? So I would say, one really important reason is assessment. So we have a requirement for some of our services, such as IBHS, that an assessment is completed across all environments for that child. So, somebody's going out and assessing what are the needs in the home environment? Are there needs in the school environment? What other needs are there? So through that assessment process, which is going to kind of link up with the written order, it's determined, okay, this is where we need this level of support. So that's really important that those clinicians are able to get out there and kind of take a look at that so that we can make sure we have the support wrapped around the whole individual. You may have professionals coming into the school because after that assessment, there may be recommendations that services are provided within the school setting. So typically when that happens, a provider agency should hopefully be meeting with some administration in the school, whether that's a school counselor, someone that's involved, have those processes set up so that they can have a collaborative relationship, but really make sure that we're linking those systems together. And I would say the biggest reason that you may see some mental health folks out there is really providing, continuity of care across settings. So if a clinician's working with a youth within the school system and they have certain recommendations or behavioral supports in place, we don't want then somebody who's providing supports in the home to do something that goes completely against that. We can make a lot more progress if we're on the same page with each other. And then one other little thing that I did want to highlight, Pennsylvania is a little tricky. We have something called Act 62, which is an Autism Insurance Act. So some folks that have Medicaid, if they also have primary insurance, their primary insurer is required to cover up to a certain portion of those services. Each insurance has its own type of plan, its own type of requirements. There are some insurances that say we will not approve certain services in school settings. That's particularly come up with ABA services or applied behavior analysis. So that's just something to keep in mind, that that may happen, that we can't deliver that service in the school setting. Speaking of ABA, I did just want to highlight, I know that ABA or applied behavior analysis is kind of a big topic. It's something, where we're really looking at, why does the behavior occur? How can we support that individual and teach them functional skills to get what they need? But ABA isn't something that's just authorized through intensive behavioral health services. That's one way to access it. It's not something that's just going to be in somebody's IEP that they have ABA supports, or they're in a classroom that's set up for a verbal behavior program. They might be accessing it through early intervention. If somebody was at a residential treatment facility, they may utilize that approach. So I did just kind of want to highlight that, because there's no one direct pathway to really accessing some of these services. So I just did want to highlight that that can be offered a couple of different places. And I will turn it over to Perry to talk a little bit more about our student assistance program.
Thanks, Amy. Good afternoon, everyone. My name is Perry Rosen. I'm a certified school psychologist and licensed psychologist. I also work in our Children's Bureau. And the two areas that I primarily focus on are our student assistance program, as well as our youth suicide prevention efforts throughout the Commonwealth. So I'm going to start by talking a little bit about SAP. So SAP is required in all Pennsylvania schools. And what we always say about SAP is, even though it stands for Student Assistance Program, it is not a program, it is really a process. This process relies on a team of trained individuals within the school setting. They get trained by approved training providers that are overseen by our Pennsylvania Network for Student Assistance Services, which I'll talk about more in a moment. And SAP really, when we think about the continuum of supports in the school, SAP falls most closely within that early identification and referral piece of that prevention continuum. So it is in place to address any barrier to learning or success that may arise for a student. So really, there's no potential referral reason that is inappropriate for SAP. SAP teams can take any kind of referral. And then through that process, they gather data and information to determine appropriate supports and services that might benefit that student. So this is the infrastructure that supports SAP in Pennsylvania, and there is quite an infrastructure for this work. SAP here has been in place for over 30 years. It actually has been recognized as a national model. Other states do have SAP, but they don't look quite like Pennsylvania's SAP structure. And it starts at the top with an interagency group that has leaders from the Office of Mental Health and Substance Abuse Services, where we're based, also from Pennsylvania Department of Education's Office for Safe Schools and the Department of Drug and Alcohol Program. So it's been this collaborative effort between these three agencies for over 3 decades, which is something that makes SAP particularly unique. And then within that network at the state level, we support 9 regional coordinators across the Commonwealth that offer technical assistance to schools, as well as the SAP liaisons. I'll speak about them in just a moment as well. And then also the counties. And they really help to facilitate best practice around SAP. There's no monitoring of SAP teams in schools. There's no policing of SAP. We always say that, but there's supportive structures to help really promote best practices and fidelity to the model. Our network, then, as I had mentioned, we monitor 23. We currently have 23 approved SAP training providers that train anyone that sits on a SAP team. So you're not able to sit on a SAP team in the school unless you've been trained. We just actually rolled out a new standardized training model so that all of those 23 trainers are now training exactly the same way. Anyone that goes to any of those 23 trainers is going to walk out with exactly the same information about what the SAP model is and their role and responsibilities as SAP team members. And then if we get down to the county level, we have county drug and alcohol, or the single county authorities, the SCAs. They receive funding from DDAP to support drug and alcohol. We call them liaisons that sit with the school teams and assist them if there's an underlying drug and alcohol concern. Through our office, we provide funds to county mental health offices to support mental health liaisons that also sit on teams and support if there's a mental health related concern. And then we have our teams in the schools. So this is just an image that reflects the 4 phases of the SAP process. Just briefly to kind of share what this looks like. Anyone can make a referral to SAP. And SAP is positioned to support any student in the school building. So even if students already are receiving services in some way, shape, or form, they may already have an IEP, they may already be receiving treatment services in the community, they can still be referred to SAP. There can still be an issue that arises where it warrants a process for the team to gather data and think about what other supports may be appropriate for a particular student. And so there's really no student that can't be referred and no reason that wouldn't warrant a referral. The team then goes through a data collection process that involves looking at school data, gathering behavior checklists, there's parent and family conversations, there's student conversations that happen, and then all of that is kind of synthesized to come up with an action plan. Unlike an IEP, it's not a legal document, but more of a documentation tool to collaborate with the student and family and be able to monitor whatever it is the team comes up with. And then there's follow-up to just determine at what point success is attained and when a case can be closed. And SAP liaisons from the mental health and drug and alcohol systems, they sit and they assist in this process. A particular role that they can have is to screen or assess a student if some of the concerns revolve around mental health or drug and alcohol. Some students are just referred to SAP because of academic concerns or social or behavior concerns, whereas others may have these additional needs. And then that liaison can do that screening or assessment and make recommendations both for in-school and also for potential community services, which may include treatment services. Yes. Oh,
If people have access to a psychologist and a school psychologist, are there things that they should consider when choosing one versus the other?
oh, okay.
The question was in relation to max capture, which is specific to school-based access program claiming. I'm going to answer that question in the chat, but we will ask for live Q&A probably at the end, and I'll answer SBAP questions in the chat. Thank you.
Okay, so I'm just going to go through a little bit of the data that we have available at the state level. So through the SAP system, we do collect data both from SAP teams. They're required to report data on SAP referrals to PDE. And then we also gather data from those liaison agencies about the liaison services that are offered, and those come through OMHSAS. And so every year, and we are just closing out our 23-24 data, so I don't have that to share just yet. But we do put out infographics every year, both from the PDE school team data as well as for the liaison agency data. And that's just a snapshot of the first page of the infographic. And you can access all of these publicly through the PNSAS website, which we've linked that website in this presentation. But just to, if you go forward, just to kind of share a little bit of the story of the last 5 years, this is the data that reflects just the number of referrals to SAP teams in Pennsylvania over a 5-year period. As you would expect during the pandemic, when schools were mostly virtual and teams were not functioning as typically they would, we did see a decrease, but then we've seen a pretty big jump up, even higher than what our pre-COVID numbers were. And I don't think this is probably surprising to most of you in the schools because you're seeing these concerns. A pretty big jump right after COVID and continuing that trend upwards. The top 3 reasons for referrals to SAP teams by far is behavioral concerns. And that category, we actually broke that out in our data collection. It used to just be behavior, but we split that up so we could look at internalizing concerns versus externalizing concerns. And then academic follows that, and then family related concerns after that. And then if we think about screenings and assessments, not every student referred to SAP is going to need a screening or assessment. And that's something important to just make clear because some SAP teams sort of operate in the sense of, really the reason to refer a child to SAP is for them to get this screening and assessment. And some do that for every student referred to SAP. We do try to emphasize that not every student will need that. So the data should really inform what you do in that sense. But you can see it follows very closely with the referrals in general, where there was that dip. And then we see a lot more students that needed those screenings and assessments following the pandemic. We also, in the past 5 years, have added items to our state reporting for liaisons to tell us how many suicide screens have you done. And we thought this was a really important opportunity to capture some suicide-related data, because really any reason that a child would be referred to SAP is technically a risk factor for suicide. So even though we're not necessarily seeing the referrals being made because of a suicide-related concern, if they're having a social concern or behavioral concern, we were really encouraging our SAP liaison agencies to still include a screening for suicide in their screening or assessment. And so this really shows that they're not required to do it, but this does show that the number of screenings that are happening, again, after the pandemic, we are seeing a lot more of that. And then finally, as far as this data, now some liaison agencies only screen, some assess. And when they screen, they're just kind of getting a sense of the concerns, but they can't make a level of care recommendation. When they assess, they can make a level of care recommendation for treatment. And so the breakdown for assessments, most of them are for mental health concerns when you compare that to the greenish color, which is assessments that took place for drug and alcohol, and the blue for co-occurring concerns. Okay, and then I'm just going to kind of briefly talk about some of the suicide prevention efforts that we've been promoting at the state level. We do work closely with some statewide organizations and PDE around this work, but regardless of whether your school building is formally implementing a multi-tiered model like PBIS or MTSS, we do encourage kind of this way of thinking in a multi-tiered way about how you are comprehensively supporting your students' mental health needs and addressing suicide prevention. So really, schools are only mandated to do things like have a policy for suicide prevention or offer training, but that is not necessarily a comprehensive approach that's going to meet the needs of all students. So we really strongly encourage schools to be thinking about what are those universal tier 1 efforts where you're working to create that safe and supportive learning environment that's going to do many things. It's going to help destigmatize mental health. It's going to help promote help seeking. It's going to help students feel safe, which is a huge protective factor for suicide. And so there's lots of pieces that go there as far as awareness, education, and then a lot of the other efforts that schools are doing. A lot of schools are also starting to think about universal screening, which is something that is growing as a practice across Pennsylvania and also nationally, as a way to be proactive in terms of identifying potential mental health concerns that students may be facing, another way to identify students early on and refer them to supports before things get much more challenging and difficult. And then, of course, we think about how do we identify and support those students when there is a suicide-related concern or other risk factor? And thinking about the red at the top, what are the strategies that we're going to then put in place for those students that we know are at risk of suicide, have already expressed suicidal thoughts, have maybe made an attempt, or how do we support the whole school community when there is a death by suicide? And so this really represents that whole prevention continuum and all those pieces. And we've pushed out a lot of resources and information all along this continuum as far as awareness materials, training, and other resources. And then I just want to highlight a couple of those resources. This is my last slide. There's certainly many more things that we've developed, supported, and offered than this, but these are a couple of the key ones. First and foremost, to support that school-wide awareness, we do work with Prevent Suicide PA and provide funding to them through one of our youth suicide prevention grants to run a PSA contest for high school students. That happens every year, and it's an opportunity for students to engage in an awareness and educational experience where they can make a poster about suicide and share some of the resources like 988, which is the 988 crisis, suicide and crisis hotline number that is a national resource. We also have a free online training site, so to support schools in meeting some of the training requirements under the law, but also going beyond that. There's a lot of free trainings on that site that they can access. We do have a higher ed coalition, and then we've worked with some parent and family and youth organizations to create a lot of free educational curricular materials that are accessible for parents and families, some tip sheets that can be shared out by schools, like how to talk to your child about suicide, a tip sheet for parents who may have a child that has had a suicide-related crisis and needs to go to an inpatient setting. So just wanted to include those for you to share within your school settings. And certainly if there's anything else you're looking for, our contact information's in here if you would want to reach out. And I'm going to hand it over to Kara.
Thank you, Perry. Good afternoon, everyone. You guys are so close to almost being finished. I see the tiredness on your faces. You're so close. Hang in there. I am Kara Kessel. I am a clinical consultant with the Children's Bureau, also a board-certified behavior analyst, and I'm going to be discussing crisis intervention services. And I feel like that's something that most schools are pretty familiar with. You have that student who is constantly acting out in class. You have that individual that your in-house supports may not know how to help. And so oftentimes, coming from a school setting previously, we looked towards crisis intervention services to be that answer. And my colleagues talked about upstream interventions. We talked about services to be in place across multiple settings. And so those are so, so important. But we're also going to talk about crisis intervention as a door to some of those services. But, one of the reasons that I was included in this talk today was because, one, districts, students, staff are utilizing crisis intervention services for their kids. But we're also hearing from the providers of the crisis intervention services that a large number of their mobile responses are to schools. And the reasons are largely behavioral or suicidal ideation with or without a plan. And so we see this reported from providers that have districts that have lots of resources. And then we see this from districts that have fewer resources. And so we do recognize, as do the providers, that districts are doing the best that they can with what they have. And so we want to talk a little bit about some of the best practice and the federal initiatives that have now come into the Commonwealth as our initiative moving forward for children and youth and young adults and their families when it comes to this service space. So really what we want to talk about is keeping kids in their safest, most familiar environments, right? So the vision is to have someone to talk to, right? So Perry mentioned 988. That's one of the answers to that. That someone to talk to could be a counselor at school. That could be, a trusted teacher. But, more specifically, we're looking for someone to talk to in a clinical sense, someone to respond to that concern, and a safe place for help. And oftentimes when we have in this space in education, a safe place for help isn't often viewed as an outpatient solution. It's often viewed as an inpatient solution or, a partial solution. And so we want to talk a little bit more about that in terms of, the services that Amy discussed, linking them up with student assistance programs within schools to maximize their resources and involve their families. So 988 has a multitude of resources. They are accessible by phone, chat, and text. And so that is a 24/7 available resource that children and youth and their families can access if there is concern, regarding a relationship, bullying, issues in schools. And, that is not to replace Safe to Say. Understanding that Safe to Say is a different type of resource. But specifically for these types of issues, 988 is a resource that can be utilized and should be utilized to help access some of these necessary services to help children, youth, and their families reach stabilization outside of an inpatient setting. Mobile crisis response, I talked about meeting with providers across the Commonwealth, them reporting that schools are high utilizers of the service for a multitude of reasons. And, we're really trying to start a new conversation about family and youth and child-defined crisis in this space, trying to start the conversation about the Just Go model for children, youth, and families. And what that means is you don't have to reach a certain threshold in order to receive a face-to-face assessment for, whatever your concerns might be. And maybe the connection to service is an outpatient, therapist. Maybe it is that they need to be connected with case management services. Whatever it is to bring that family in, bring that child in, could be available through that Just Go model. Co-responder models also exist within this mobile crisis response space, and that is a mental health worker that is teamed up with a law enforcement officer, and it looks different with each department, with each jurisdiction, but it is most often an unvested individual. I'm talking about a bulletproof vest, so they look, more approachable, comfortable, etc. But they're there to assist in any type of behavioral health call that might come into 911. In this space, just so everybody is aware, there's a focus on precincts and law enforcement officers receiving CIT training. So that's crisis intervention training. I know specifically within some local police departments here, there's youth-specific focus. There's development around that. So the systems are trying to support the need that we all know is so present. Some other resources that exist in this space are behavioral health walk-in centers. So this is something that's, I would say, a little bit newer in terms of how we're trying to provide a safe place for help. So this option, and there is actually one opening pretty locally here, hopefully in November. And I feel like some of you know, because I see some smiles and some head shakes and nods. But it is a opportunity for individuals, and here we're talking children, youth, young adults, and families, to go and stabilize whatever situation they find themselves in, get potentially the connections or the referrals or the resources that they couldn't get elsewhere, but then they can go back home. The child can go back to school the next day. They can see their friends. They can participate in that activity. And that is what we're finding is providing the best outcomes for children, youth, and families in this this time and space that we find ourselves in terms of, just everything's more difficult now. And I think, we as educators, as clinicians, as people who are involved with children see that. Crisis stabilization units, that is something that is that next step. So if 23-hour stabilization wasn't necessarily enough, it didn't meet the need, this is an opportunity for that individual to stay in an environment that is not considered a partial or is not considered an inpatient setting, but it is typically 48 hours to 7 days. That is generally what you would be looking at in that type of setting. But again, the focus is short term. It is providing the resources to stabilize now to then get that child back into their home or a safe environment to get them back in school, back learning, back in sports, whatever it is they're doing that really makes them who they are. We, with the resources and services that I briefly mentioned, and as did my colleagues, we are really looking for an effective way to support Pennsylvania families, children, youth, and young adults. And, specifically within the crisis space, the goal is to decrease those kids and those young adults, those adolescents, those families sitting in emergency rooms, waiting for an assessment, waiting for a bed. And oftentimes they don't receive, I shouldn't even say oftentimes, 99.999% of the time, they don't receive treatment while waiting in that emergency department waiting room, to no fault of anybody there. And that's why the behavioral health walk-in and the crisis stabilization is such a resource that, we're encouraging people in need to utilize, because yes, they may wait a little bit there. However, there are goals around timeliness, but in terms of waiting, they are accessing help and treatment more immediately than they will in that emergency room. The other goal is to decrease restrictive placements. There is definitely the need for those placements when the need exists, but most times we can do something prior to that type of restriction being necessary. And I think the Just Go model that I mentioned earlier, getting eyes on that kid, getting them involved in services that could potentially, give them resources or an outlet to discuss their frustrations, their sadness, their feelings, could help prevent some of those things. It is very important that with schools being such a high utilizer of this service, that we are partnering together, that we're understanding the needs of the schools, that we're understanding how to best support schools. And so, I would like to just put that out there at this time to let everybody in this room know that moving forward, there will be enhanced attention in this space, specifically regarding children, youth, and young adults and those initiatives for the Commonwealth. And so, I really do, the surveys and everything that, you guys receive, it can just seem like another survey. And I feel like it's probably what you're going to talk about here in a minute. But maybe as a nice segue, what you have to say matters. And it definitely can help shape and redefine services to keep our kids home and in school.
Thanks, Kara. Yes, we're going to wrap up. I'm going to switch over here. So, and yes, to follow up on that, I mean, the best way for us to know what's going on with you all is to reach out. And because there are so many of you, a lot of that is going to be via survey. So some of the things that were brought up today, like ABA services, where we don't have the ability for you to bill for some of these kinds of providers. This is information that we're going to be looking for. What is the scope of students who are receiving these kind of services? Is this an area that's going to be maybe top on your lists as we look at the expansion of school-based services beyond just students with an IEP? And listening to and looking at the types of referrals that occur within SAP. If that program is feeding so significantly into some of these other health related needs, can we identify a path that allows some of that to be part of school-based? Can we stop looking at SAP as a solely educational function? I don't know the answer to that. That's just one of the things that we're hoping you guys will think about and, share what your experiences are so that we can consider that as we move forward. So over the next, and it's probably not going to be 12 months. I don't know, maybe it could be, but definitely over the next 6 months, there will be a lot of outreach to gather feedback from you all to determine the path forward. So, and we've talked a little bit here and there about the technical assistance grant that DHS was awarded by CMS and the new guidance that came out in May of 2023, which is really driving the changes in the program and the potential changes in the program. The October 2nd coffee hour is actually, I'm looking at Stephanie because I asked this, so hopefully it's where that coffee hour will actually be devoted to a presentation specific to the grant. But we are also hoping with the beginning of the year to try to make a trip around the state and visit some towns like we used to do with fall training. But you know, things went virtual and then the higher up said, "Ooh, that's better on the budget." And so we don't get to travel as frequently anymore, but we're hoping to do that at this juncture because there are potentially so many changes that could happen within our school-based access program in Pennsylvania. So when we talk about the changes that have to be made, I know a couple times today we've talked about we have to do something a certain way because it's part of our approved Medicaid state plan. That's where our school-based services sit. So when we talk about providers and service types, that's the document that has to be updated before we can tell you, yes, you can bill for these folks. And that document has to go to CMS for approval, which means that it's something that does take time. So we just hope that you'll hold on and take the ride with us as we see where this program goes. Some of the specific goals, and these are things that were set out by CMS when we were granted these funds. We are to be looking for program and infrastructure needs. So these are the kind of surveys you're going to see. What can we do in the behavioral and mental health service space? What can we do to expand to cover non-IEP students? And what does that look like? And I know I mentioned this in at least one presentation yesterday where this new guidance is really looking at school as a location where EPSDT services may be provided. And EPSDT is very sweeping and covers a lot. And so that can potentially open some more doors for us. And of course, CMS wants to see that we're increasing participation so hopefully if we identify some of the barriers and things, then we can work towards addressing any of those that we can try to make a little easier for you. So I just want to thank again our friends from OMHSAS for joining us today. I hope that you found their information beneficial. And like I said, I hope it will trigger some questions for you or some thoughts for you that you can send to us as we think about how we can better support in this space through the school-based access program. So, and yes, we have another survey for you to provide feedback on this session, but also we have expanded the resource accounts that we are using at DHS. So future surveys and bulletins and things are coming from this no reply resource account. So make sure that your LEA marks those as safe so that you're getting those communications. So we will open up if we have any questions that we can be addressed this afternoon.